All right, we're right at 9:04, so we'll get started with introduction so we can get started with the talk on time. I'm absolutely delighted to introduce Dr. Sara Lewin, our gastroenterologist who specializes in caring for patients with inflammatory bowel diseases and disorders. As I'm sure the first years are already learning, IBD is a big strength in our program, and that's in no doubt in part due to Sara and her help treating us on the inpatient wards for IBD. Dr. Lewin earned her medical degree at UCSF, where then she completed her residency in medicine, followed by fellowships in GI and IBD. We've been incredibly lucky to retain her. In addition to evaluating patients in clinic, she performs EGD, colos, capsules, and a double balloon enteroscopy, which makes her exceedingly valuable to our department and my own personal education. She is the Associate Program Director for the GI Fellowship, which we have all benefited from, her warm care of us included, and is the Director of Inpatient Consult Service and the Co-Chair of Endoscopy Governance Council at UCSF Health. Dr. Lewin's research interests include improving care for her hospitalized patients with GI illnesses and the complications of IBD. She's the site PI for a number of industry-sponsored clinical trials at the UCSF Crohn's and Colitis Center. Truly, no one is more, we're not in the most excellent hands to learn about inpatient IBD management from Dr. Lewin, and I'm excited for her to take this talk away.
Great. Well, thank you, Molly, for that very kind and generous introduction. I'm really happy and thrilled to speak with you all today. So my goals for today really are to be able to give everybody a framework for how to care for hospitalized patients with IBD, but also provide some updates in the literature in the last year. So although some aspects of this talk may be familiar to those who have heard me talk on this subject before, I also hope to give you a little bit of state of the art as well. So I have no relevant disclosures for this talk. And then in terms of the sort of proper learning objectives for today, our plans are to articulate indications for hospitalization for inflammatory bowel disease, describe the initial or kind of what we call day one management of patients hospitalized for IBD, identify complications of IBD hospitalization and the steps that we can take to prevent them. And lastly, determining the best strategies to promote a safe discharge and prevent readmission. So I will start with a case, and I will be calling out folks, so just do be prepared. I hope these are low pressure questions, but just we'll be kind of taking turns popcorning, so don't want to catch anyone completely unawares. Our case here, we have an 18-year-old man with a history of asthma who's presenting to his local GI with 3 months of bloody diarrhea. His initial workup includes negative infectious stool studies. He has a relatively normal hemoglobin, maybe slightly low, mildly elevated ESR, normal CRP, calprotectin, kind of indeterminate or borderline. But 2 days later, he undergoes colonoscopy. That's the beauty of community practice, as often we can get people in very quickly. And as you can see here, he has, significant colitis, and the pathology on biopsy shows chronic active colitis with distortion of glandular architecture, which is kind of consistent with what we would expect for ulcerative colitis. So his local gastroenterologist started him on budesonide, Uceris formulation for colon release, Lialda 4.8 grams daily, and Rawasa enemas. And at 1 week follow-up, he seemed to have improved. His stool frequency went down to two per day, but continued to have some blood in the stools. And then, despite some initial improvement, had a relapse of symptoms and presented to the emergency room with 8 bloody bowel movements per day and abdominal pain. He was afebrile, heart rate 95, normotensive. Hemoglobin now is 9.8, albumin 2.9, CRP 21, and ESR 52. So for our GI squad, our first year fellows, I will ask you this question. So first I'll ask Royce this question. Does he need to come into the hospital?
Since he's having 8 bowel movements a day that are bloody, it sounds like he probably should come in for a steroid taper as well as consideration of a biologic induction if he's kind of not really doing well on non-biologic therapy outpatient.
Great, excellent, perfect. Well, thank you, Royce. The indications for hospitalization are, like you mentioned, severe disease, and we'll talk a little bit about what that means. Toxic megacolon, certainly, and then failure of outpatient medical therapy, which is what he was presenting with as well. Other indications for hospitalization include complications of the disease, complications related to medical therapy, such as opportunistic infections, and then severe extraintestinal manifestations, like a severe pyoderma flare, for example. So the real question is, how do you define severe UC? And we use this True Love and Wits criteria, which is for the severity of, is a very old classification system with the using this sort of algorithm or rubric to define how we would, what we would call sort of severe ulcerative colitis. So in this case, having greater than 6 bowel movements per day, blood in the stool, any signs of temperature dysregulation, elevated heart rate, which is kind of that SIRS or systemic inflammatory response syndrome type of physiology, significant anemia, and then elevated sedimentation rate greater than 30. And so this is kind of how people get categorized if you meet criteria for one of the following of these buckets. So apart from ulcerative colitis, we have other reasons that folks will get hospitalized with inflammatory bowel disease. So certainly for ulcerative colitis, severe colitis, characterized by the True Love and Wits criteria. Another additional criteria, which is just kind of a subset, but should kind of put up your spidey senses about whether more urgent intervention, surgical consultation, et cetera, should come into play, is fulminant colitis, which is described as 10 or more bowel movements per day associated with fever, abdominal pain, distension. And those are people you're really worried about having, perforation, toxic megacolon, et cetera. And then in Crohn's disease, the reasons that patients are hospitalized is really one of 3 buckets, is how I think about it. Kind of similar to ulcerative colitis, severe or fulminant enterocolitis, bowel obstruction, either due to an inflammatory burden or from sort of fibrotic or stenotic consequence of longstanding inflammation, and then abscess, whether a severe perianal abscess or intra-abdominal abscess. And certainly the colitis and Crohn's enterocolitis are managed similarly, whereas bowel obstruction and abscess have their own management pathway. During this talk, I'm going to mostly be focusing on the colitis and enterocolitis management, but we will touch upon bowel obstruction and abscess management. So the case continues. Based on True Love and Wits criteria, he does meet the definition of severe UC, and he's admitted to the medicine service, just like Royce had recommended. So I did want to raise your awareness for those of you who are practicing at UCSF Health that we do have this inflammatory bowel disease addendum. Basically, it's an order set that you can actually let the ordering hospital medicine team know about if they haven't put this in already, which basically comes with a full set of what we would recommend for admission labs, as well as a daily labs, being able to follow CRP, albumin, as well as recommended stool tests. So just something that you can be aware of, or if you wanted to look at and reference for making sure that everything appropriate has been ordered. All right, so this next GI squad question is for, I saw Sean's camera was on before, so I'll pull you up next. What are the rate limiting steps in his care that must be accomplished as soon as possible?
A couple things come to mind. One is ensuring no other GI infection with like repeat infectious stool studies. And then to Royce's point about like induction with the therapy, making sure he has like pre-testing done. So hepatitis B and then PPD or quantiferon if he hasn't had that.
Perfect. I love it. Awesome. Thank you, Sean. So you nailed it on the, nailed it completely. So C. diff testing, and this is an area of study that we're actually looking at actively with our UCSF inpatient IBD cohort, whether you actually do have to wait for C. diff testing to come back before you can either start IV steroids or biologic therapy. TB testing and hepatitis B testing, because we do want to be able to know if there's any sort of latent or untreated infection that could be become more active in the setting of more significant immunosuppression with biologic therapy. And the last thing, this is usually doesn't happen, but this has come up once or twice. It's actually delayed care for up to 12 hours or so, is a weight, because our infliximab, one of our rescue therapies, is weight based, and so if for whatever reason you don't have a weight you can't know, the pharmacy doesn't know what dose to cook up. And so sometimes if that hasn't been done, that can certainly delay things. So, but mostly I think the things we think about are C. diff, TB, and hepatitis B. All right, so the C. diff returns negative and a PPD was placed on day 1. And so the question of this often comes up because PPD takes a lot more activation energy on the part of the bedside care providers because they actually have to go and get a tuberculin, and they have to, get a needle and do the whole procedure as opposed to just kind of clicking a button and adding it on as a lab. The challenge, though, is that QuantiFERON, at least at UCSF Health, is a send-out test, and so the turnaround time is many days. I've seen it take up to a week for a QuantiFERON to come back, and so certainly if we're waiting on tuberculosis testing before starting a biologic or rescue therapy, we don't really have the luxury of time to be able to wait for that QuantiFERON to come back. Whereas in the outpatient setting, often we're not, we're getting insurance authorization. There are other sort of roadblocks. And so QuantiFERON is more appropriate. But for in the inpatient setting, a PPD really should be placed on day 1. And so that's probably the biggest thing that will hold up people getting rescue therapy in a timely fashion, is that PPD is in place. So something to be super mindful of when you're getting consults for these patients who may ultimately need biologics, is to ensure, like, even if it's 4 o'clock in the afternoon, like that PPD should be done that day. His Hep B serologies are pending, and those typically have a little bit of a faster turnaround at UCSF Health. So that doesn't tend to hold things up. It's usually a day or 2. And what's amazing, this is a real case, that the fecal calprotectin was rechecked and it was actually greater than 2,000, and it was 90 a week ago. And so just goes to show that ulcerative colitis flares, Crohn's flares can really turn on a dime, and people can have numbers that look overall reassuring and can have significant changes in their physiology that leads to, a significant inflammatory reaction. So just wanted to highlight that you don't necessarily have to check the calprotectin, but in this case, because it was 90 and he's coming in with such severe symptoms, it was reasonable to recheck so that we have a better baseline going forward to know, okay, is this someone who doesn't really mount a fecal calprotectin despite significant inflammation, or is this someone who we just hadn't captured them? So he started on IV methylprednisolone. And then the next question for our GI squad, I think I saw I saw Karina's name. So Karina, can you tell me what dose of steroids roughly do you think that he should get? And if Karina's not free, I will phone a friend.
Hi, I'm here. Sorry, I was just moving to the computer to unmute. I am actually not sure what the dose of steroids would be.
That's totally fine. So typically we do 40 or 60 milligrams of IV methylprednisolone or solumedrol, but no data to go higher. So there's no data for, the scleroderma, or like for, 1 gram of solumedrol or those kinds of things. So it's really beyond 60 milligrams. There's no benefit. So sometimes patients will come in and they'll feel a little bit better if they're on IV methylprednisolone 40 milligrams, which is our usual standard dose. Sometimes we'll increase it up to 60 milligrams, but there are patients who are like, I just need more. I've had patients argue, like, in the past, I've gotten 125 milligrams and I felt so much better. But there's like very clear data that there is no benefit for higher doses than 60 milligrams. And then our ECG guidelines codified this. So our standard dose in practice is 40 milligrams with the ability to go up to 60 milligrams in the appropriate setting. Mostly just that we're not wanting to put people on we want to try to see if we can capture a good response. And there's probably very marginal incremental benefit between 40 and 60. Okay, so this is the picture actually of this from this actual case of the flexible sigmoidoscopy that's performed, and that's recommended to do within the first couple of days of the hospitalization, not only to be able to stage the disease to see how much disease activity there is, because sometimes people will come in and they're reporting, 10, 12 bowel movements a day with blood, etc. But actually the etiology is something different. It's not their ulcerative colitis that's active. And so it's really important before we kind of anchor on, oh, well, the patient is saying what their symptoms are. They have signs of inflammation on their labs, let's say. It's really important to sort of confirm that there is sort of severe inflammation, because we shouldn't be sending someone for a colectomy who has, sort of mild to moderate disease on their endoscopic evaluation, or it may prompt us to do colonoscopy or other imaging or things along those lines. I just showed this picture also because this is how bad the image quality used to be on Pentax. It's so much better now, and I'll just kind of review here. This is the Mayo subscore, which with much higher quality photos, which I think our updated scopes now have. And I know that this one was reviewed with your earlier talks with Dr. Chug and Dr. Beck, but in terms of thinking about the endoscopic scores, we really can see beautifully here the Mayo endoscopic score of 0, beautiful arborizing blood vessel pattern here that you can see. Whereas Mayo 1, you can see a little bit of erythema, some decreased vascular pattern. Mayo 2, you're really starting to see loss of vascularity completely with erosions, which are these kind of little white pieces here. And then with Mayo 3, really seeing spontaneous bleeding being the big difference. I would say the vast majority of patients who are coming in with an ulcerative colitis flare are going to have Mayo 3 disease, sometimes Mayo 2, but for the most part, you're going to see a pretty severe active disease like this. The other thing that that is important on flexible sigmoidoscopy is to take biopsies to look for signs of cytomegalovirus that can also mimic an IBD flare and cannot be tested in any other modality other than sort of direct visualization looking for viral inclusion bodies. There's low utility in getting sort of a PCR, CMV, either in the blood or even just from the tissue itself. We used to do viral cultures for CMV, but there is a fair amount of colonization of CMV without causing any sort of true infection. And so at this point, the standard of practice is to take biopsies only for CMV to be able to assess for any active infection that may require treatment with antivirals rather than further immunosuppression. So moving on to kind of help organize all this. So that was all the day one stuff, or like the stuff that has to happen in the beginning, right? So the initial labs, making sure that we have, all the rate limiting steps done, like the C. diff, PPD, hepatitis serologies, weight, getting IV steroids started, getting patients in for a flexible sigmoidoscopy. So that's kind of like the initial day one stuff. And now moving on to sort of what you do every day, there's a kind of daily checklist that we recommend kind of framing how we care for these patients. So this is derived from a paper that I had put together with Dr. Fernando Verlayos, going through kind of a day-by-day guide for management of the hospitalized patient with inflammatory bowel disease. And this essentially is kind of a mock-up of what the checklist would look like. And so essentially the guide, sort of the guidepost for each day is to go through these different buckets of assessing disease severity and extent, doing any additional diagnostic evaluation, getting therapeutic interventions and planning, assessing response to therapy, and then looking ahead towards discharge with all of this. So this is available in the box for today's talk, as well as you can certainly download the article as well, but this checklist should be here. And then we also have a dot phrase that is available, or a smart phrase available in Epic that you can use on a day-to-day basis for kind of following through and checking through all of these things. So to kind of go in a little bit more granular detail for our daily tasks. So the first task is to really assess the disease and extent. And so to get an idea about how much of the intestine is involved. Is it their proctitis? Is it left-sided colitis? Is it pancolitis? Because that certainly predicts the severity. And then in order to really measure that, we can use the simple colitis disease activity index. And I don't think you have to necessarily calculate this on a daily basis, although if you are feeling motivated to, great, everyone loves data. But I think this is really the questions that you should be asking patients on a daily basis when you're assessing them and trying to get a sense about the severity of their disease in that day. In particular, a lot of these questions, if you just kind of go in and ask somebody how they're doing, you can get a very biased response, because people really have, when they're hospitalized with colitis symptoms, they can have a part of the day where they feel really good, they haven't really had any bowel movements, they've gotten up and walked, they've eaten something, and then later that day they can have horrible abdominal pain, lots of bowel frequency, urgency, blood, aren't able to get out of bed. And I think it's really, I've definitely been fooled when you go in and you see someone and they say, I'm doing fantastic. And you're like, okay, great. Well, like, let's get ready to have you leave the hospital. But then just a few hours later, things are totally different. And so I think getting a sense about over a 24-hour period, what has the stool frequency been? And often we'll ask patients to kind of keep a tally, basically like on a little whiteboard in their room or on a piece of paper, so that they can kind of report, all right, I had 12 bowel movements over the last 24 hours. I had, 6 overnight. And then you can kind of get a sense about urgency. Are they having accidents? How much blood is in it? Is it all blood that they're passing? Is it getting more formed? You can also get some data in terms of how people are progressing by assessing their disease activity index kind of roughly each day. And then for Crohn's disease, in terms of assessing the kind of extent of disease or behavior of the disease, is thinking about which of those 3 buckets that the Crohn's presentation falls into. So for inflammation, or really more of like an enterocolitis type of presentation versus more of a obstructive or penetrating complication, hospitalization, kind of understanding which of those 3 are active. And then you can use the Harvey-Bradshaw index as our best validated index for assessing symptoms. And so again, things like abdominal pain, stool frequency, if they have a mass or protrusion, and then also activity of extraintestinal manifestations. Daily task number 2 is to review the diagnostic tests. I would argue that everyone should have a blood count, chemistry panel with an albumin, and a daily CRP to follow. So those are the main things that should be followed on a very regular basis. Other labs that should be ordered at the outset that may take some time to come back are sort of assessment for micronutrient deficiencies. We typically recommend checking vitamin D, B12, and iron studies, following up any outstanding infectious stool studies, not only because we want to make sure there's not a Campylobacter infection that may have been mimicking things all along, but also we would love to be able to discontinue contact precautions for these patients, so they don't have to have all their providers gowning up every time they come into the room. And then following up any pending hepatitis B testing, tuberculosis testing. And I didn't mention this as a true rate limiting step because I think our practice patterns are shifting, but you could make an argument that if there is a plan to transition to a thiopurine-based regimen in combination with rescue therapy, that you would want to have a TPMT level cooking so that if the patient is a candidate for using thiopurine therapy or if they need dose reduction. But I think for the most part, our practice at UCSF is not to necessarily start combination therapy in the hospital. And if we do, the majority of patients, I think our group practice is prefers to use methotrexate as opposed to thiopurines. But in the appropriate patient, that may be another important test to get checked and cooking as soon as possible. So for daily task number 3, and this I know is also in one of the dot phrases we have for managing our IBD patients, is really to minimize medications that can cause problems. So opiates, anticholinergics, and antidiarrheals. And the reason that we want to avoid these things is not only will it mask symptoms, right? The opiates, anticholinergics, and antidiarrheals will slow down bowel movement frequency, but can also lead to bowel dilatation, which patients who are hospitalized acutely with inflammatory bowel disease are already at risk for, and can potentially precipitate perforation or toxic megacolon. So that's why, and we'll talk a little bit more about pain management later because that obviously is a challenge. For the other thing that's really important, that it's easy just to put in your note like VTE prophylaxis, but there are so many layers that go into a patient actually receiving VTE prophylaxis. So of course it has to be ordered, and then it has to actually be administered. And so there's kind of a number of steps that have to happen. The patient has to be willing to receive it and have education about why VTE prophylaxis is needed, as well as sometimes even the nursing staff will be like, oh, well, they're young and ambulatory and they're not at risk for VTE. But we actually know that patients with IBD at baseline have an increased risk of VTE. And when they're hospitalized with these acute complications, their risk of VTE is much, much, much higher. It's sort of eightfold compared to their sort of age-matched controls. And basically short of cancer and heart failure as other admission diagnoses, the rate of VTE is the highest in IBD, kind of second to those diagnoses. So it's really, really important to try to protect patients against a VTE profile, against VTE, and have them encourage them at all the levels to accept VTE prophylaxis. A question that often will come up as well is, well, the patient's having bloody diarrhea. Like what? We're giving them VTE prophylaxis. We're giving them blood thinners. But that actually is not contraindicated, because the bleeding that occurs with inflammatory bowel disease is really more of a like sort of capillary leak as opposed to a true arterial or arterial type bleed. And so VTE prophylaxis really doesn't meaningfully contribute to blood loss. And that has been has been sort of replicated in a number of different studies. Additionally, if there is a procedure planned, we're not planning on doing a hot snare polypectomy or sphincterotomy or any of those other high risk interventions that you may recall from your early endoscopy lectures from the ASGE guidelines. Flexible sigmoidoscopy with biopsy is a low risk bleeding intervention. And so you can actually continue VTE prophylaxis even through that based on those guidelines. So no need to stop VTE prophylaxis for the flexible sigmoidoscopy, no need to stop it if they're actively bleeding. And just to kind of back this up, there was a really nice study that looked at sort of a number of meta-analyses at this, and essentially the number needed to treat and hospitalize acute severe ulcerative colitis patients is 35 in order to prevent one VTE. The number needed to harm, where there was bleeding complications requiring blood transfusion, was 114. And so the risk benefit definitely, especially because the consequences of VTE are probably much greater than, having some blood loss and needing a blood transfusion. Kind of similar to when we often talk about, patients who need to be on antiplatelet or anticoagulants for their various cardiovascular conditions. We can always give some more blood back, but the consequences of clot are significant. So that's really my big pitch to try to encourage patients and try to encourage all levels of care providers to ensure continuous VTE prophylaxis coverage. All right, so we've kind of gotten through that first day, and after getting started on IV Solu-Medrol, the patient has a few questions. So what can I eat? So I'm gonna now ask Ava, what kind of diet are these patients recommended to have?
So I'd start really slow and conservative with him, making sure he can tolerate fluids without it worsening his diarrhea and symptoms, and then usually can progress to like a low residue diet if he's improving clinically.
Great. And so I think there's a lot of iatrogenic malnutrition. So basically, I think a slow advancing of diet. So regular diet should be offered unless, they're not tolerating it. So you can start slow, low, kind of like soft foods, clear liquids, and then kind of try to progress through. But if someone's hungry and they're like, I want to eat an omelet and this, that, and the other, like you shouldn't stop them from doing that. There's no rule that they cannot have certain foods. And up to 44% of patients who are hospitalized with acute severe ulcerative colitis are actually unjustifiably made NPO or clear liquid diet just because. And so I think listening to the patients, making sure that we're advancing, open to advancing them if they're interested and they're wanting to. And this is particularly important because, if these patients end up needing colectomy, that, wanting to optimize their nutrition status as much as possible. So I think that that's, something really important that, certainly when they first come in, if they are really not tolerating anything, we just want to get them teed up, let them have bowel rest if that's kind of what the patient is being driven by, but truly should be no hard and fast rule about what they can and can't eat. One question that has come up, and this has been studied now, I think it's a lot of enthusiasm in Crohn's specifically for exclusive enteral nutrition. And so for exclusive enteral nutrition, in the outpatient setting, there's been interest in use of EEN for Crohn's disease. There was actually a recent publication a couple of years ago that looked at the use of EEN in hospitalized UC patients. And it was a small study, so it didn't show any difference in colectomy rate, but may augment steroid responsiveness and the need for rescue therapy. May also help with nutritional intake because patients don't really feel like eating anything, but if it's sort of almost like a prescribed diet, that it may help to just boost their nutritional stores if they're not able to really eat much. And then you could also think about EEN and Crohn's patients who may ultimately need surgery. There's increasing data to suggest that exclusive enteral nutrition or even TPN prior to surgery may be helpful to decrease inflammation and improve nutrition and surgical outcomes. Something that can come up is whether patients should be started on TPN. And I think we will really do want to try to encourage patients to use their gut as much as possible. And so TPN is not routinely recommended, but certainly for patients who have a bowel obstruction and they're not able to have a feeding tube placed distal to the obstruction, if they have high output enteric fistulas and really do need bowel rest, if they have short bowel syndrome, or as I mentioned, TPN for sort of preoperative nutritional optimization. If we know someone's going for a colectomy in a couple of days, sometimes the surgeons will recommend getting some TPN started to just really get them tuned up nutritionally if possible. So this is the sort of some of our recommendations for diet. Another question that often comes up is how long will I stay here? And I always thought about this a lot as a fellow, especially because I think that IBD patients are some of the few patients that we will often stay on the consulting team for the entirety of of a patient's hospitalization because their primary problem is really this GI issue that we need to have input on a daily basis. Whereas, someone who has a GI bleed, they may come in, we do an endoscopic procedure, we make sure that they stop bleeding, and then we can sign off. But for these patients, we will follow them also. So the question is, how long will I stay here? And also, how long will I have this consult on my list is maybe the flip side of that question. And just kind of to keep in context, the average length of stay in our cohort at UCSF is basically a week. And it's been reported in other cohorts, between 5 to 13 days. But I think preparing patients that they will likely be in the hospital for about a week or so, because a lot of them are like, well, I'm busy, I have other things I need to do. Can I get out of here by the weekend? And I think being realistic that the typical turnaround time is, about a week. And if they're not responding, typically longer. And so we know that increased length of stay, increases the risk of complications as well as the likelihood that they're going to fail their therapy because they're typically not responding. And I have this picture of the Zen garden because our patients, when they are hospitalized, there's often not a lot of active care that's being delivered in terms of like medical interventions and multiple drips of IV medications. And it's not a super like labor intensive hospitalization. So it's kind of like we just have to be zen. Each day we're going to rake the sand a little bit in our rock garden and just make some small changes while we kind of work through the hospital stay. And then another question that comes up is often, and this is probably one of the most challenging things, is about pain management. So a lot of patients will come in with significant pain, and that's often what's driving the hospitalization, right? They can hang at home, going to the bathroom 10 times a day, maybe they're not eating much, but when their pain gets out of control, that's often the thing that's driving people to the hospital because they're not able to cope at home and manage. And the unsatisfying answer is that the mainstay of pain management in IBD is control of the underlying disease, right? And so if they have inflammation, use immunosuppressants to get rid of the inflammation. If they have a stricture, do our usual small bowel obstruction management. They have an abscess, antibiotics and drainage, and then they'll feel better. But the challenge is that it can take time. And in the meantime, we have to avoid opiates because, as I mentioned, all of these, concerns about increased bowel dilatation, masking symptoms, and then also the predisposition to long-term opiate use. We had shown in our cohort that patients who were opiate naive but were prescribed opiates in the hospital had a much higher risk of sort of prolonged opiate dependence post-hospitalization. And so I really advocate for using other types of pain modality rather than just say suck it up until the IV steroids kick in. And so thinking about alternative pain modality regimens like neuromodulators, things like gabapentin, even getting pain intervention involved to think about things like IV ketamine, et cetera, to really try to use multimodal pain management in an effort to try to avoid opiates as much as possible. So then the next question that comes up, what happens if I don't respond to IV steroids? And so there is these old indices, the Ho index and the Travis index, that can help predict at 72 hours or day 3 whether someone is at high risk for steroid failure and should therefore high risk of colectomy and should go forth with rescue therapy. I think the paradigm has shifted a little bit in that if patients are sick enough to be in the hospital, they have severe colitis, we're kind of thinking about this more of a treat to target type of paradigm. And really these patients need to be on advanced therapies. And so I think most of the time we're moving towards getting patients on rescue therapy, kind of regardless of what their Travis and Ho index is. But this is helpful to basically say, like, you can't just be discharged on steroids, go home and maybe start Entyvio if you're feeling better. So patients who are at high risk for steroid failure based on their stool frequency, if there's colonic dilatation, hypoalbuminemia, or their CRP, can help us determine whether at day 3 they really should start rescue therapy. And so when I say rescue therapy, I've kind of already alluded to that, but basically rescue therapy is something that rescues people from colectomy. And so in this case, he had 3 days of IV steroids and really had made no progress. And so we plan to start infliximab, which is kind of our mainstay rescue therapy in our current era. Things are rapidly shifting and there's a lot of interest in other types of rescue therapy, but for now, infliximab really remains the mainstay. And infliximab is an anti-tumor necrosis factor biologic. It's been around for now almost 30 years, so it's really our tried and true as well. And so the question then comes up, which dose should we use for our hospitalized patients with acute severe ulcerative colitis? 10 mg per kg or 5 mg per kg? And I would say probably most people, we end up using 10 mg per kg. And part of that is because most of our patients who are really sick, they have low albumin. So the thought is, albumin is required to bind to the infliximab molecule. So we think these patients are at high risk for drug loss through the stool. They're not going to have good therapeutic levels. So more is better. Let's just give patients 10 mg per kg. They're inpatient. They don't need insurance authorization. What the heck? Why not do 10 mg per kg? But there's been actually a lot of interest in answering this question that's kind of come out in the last year or two. And so this clinical trial called Predict UC, which had 13 Australian tertiary hospitals participating, and patients were randomized to get either 10 or 5 mg per kg. And they really was no statistical significant difference between the groups. That the proportion of patients with clinical response by day 7 was essentially the same. The time to clinical response, maybe a wider range of responses that we can see here with a 5 mg per kg, but really no significant difference. So I think that doesn't sit well with a lot of us, because we feel like, no, we need more is better, that these patients, their albumins are low, this is wrong, this is too general. And so I think there was a lot of kind of backlash around, well, no, we should still give people 10 mg per kg. And so as a follow-up study from this cohort, they basically were like, okay, well, maybe a personalized approach. If your infliximab threshold is, if your infliximab level is super, super high, then maybe you are okay. But if it's low, then maybe you should get an additional dose. And so this kind of looking post hoc at the data from Predict UC, they found this cutoff of basically 58 for an infliximab level had an 83% specificity and 97% positive predictive value for avoidance of colectomy. But that patients with low infliximab clearance, basically, if you give them another dose, you can give them 5 mg per kg or 10 mg per kg. A dose intensification doesn't make a difference. And so maybe you could say you give 10 mg per kg for patients who you're worried about, high clearance of the drug. They kind of sort of backtracked a little bit to try to answer this question. The challenge is our assay does not detect levels above 40. So we would have a hard time being able to actually use a threshold of day 3 infliximab level to know who to redose. And on top of that, our turnaround time for infliximab levels is not very quick. Some labs have it, hospitals have it as one of their in-house labs, but for UCSF Health, it's a send out. So this kind of using this as a determinant for who should get more infliximab, we don't really have the tools to do that. So I think we still sort of feel like, well, because we don't know, I think we'll still give give 10 mg per kg, but just kind of seeing that there's a increasing amount of evidence that perhaps that's overkill. And then the last thing this is in press, so this hasn't been published yet, but it was presented at ECHO earlier this year, the European Crohn's Colitis Congress meeting that basically looked at doing a personalized dosing response for hospitalized patients with acute severe ulcerative colitis, and basically didn't show, maybe there was a improved clinical response, but no change in the primary endpoint or endoscopic response with personalized dosing of infliximab. So there may be a hint that's there, but again, by far and away, although we still do 10 mg per kg for our patients, I think it's mostly kind of to treat ourselves. All right, so he starts 10 mg per kg times 1, and he wants to know what are the chances that he'll respond to infliximab. So what are the chances that rescue therapy will work? Even with rescue therapy, in-hospital 90-day colectomy rate is still 20 to 30%, and across a number of studies, including the accelerated dosing studies. Going back just even a couple of slides, if you recall, that response rate at 7 days was 61 to 65%. So still a lot of people are going to require colectomy. And so, unfortunately, in this case, he still didn't respond with 6 bloody bowel movements. His CRP still is 40. He's really just kind of not making much progress despite 3 days of infliximab. He's been in the hospital now for almost basically a week. And so should we give him another dose of infliximab, try to see is more better? And we kind of talked a little bit about if we had the tools to check drug levels, maybe that would be helpful. But in general, this is a meta-analysis that looked at this question of accelerated dosing, and it doesn't really seem to improve colectomy rates. And so I think that although it also makes us feel better, more is better, more infliximab, let's see if we can get them over the hump. That if they're not really responding after that initial dose, unless we have reason to think that they're clearing it super quickly, that additional doses probably aren't going to help.
So can I ask you a question?
Yeah.
Sorry. For the colectomy rate from the rescue therapy, that 20 to 30%, does that also include Rinvoq at the rescue therapy?
No, this is all from the accelerated infliximab dose. So that Rinvoq is an upadacitinib and JAK inhibitors I'll talk about in a second, but that I think is really changing the game in terms of what our colectomy rates are. It's still too early because, as you'll see, the state of published data for the use of JAK inhibitors as rescue therapy is we're still at the case series level in terms of getting good data. So we don't have adequate longitudinal data to look at things like colectomy rate yet.
Gotcha. Thank you.
Yeah. All right, but you perfectly teed me up for the case. So we consult colorectal surgery. The patient's hesitant and he says, I just got diagnosed with this 3 weeks ago and now you're going to take out my colon. I'm 18 years old. Please, is there something else that you can give me? And so we'll talk about JAK inhibitors, but I think I did want to talk about the role for surgery first. And so this is when there's a lot of philosophical debate about when to get surgery involved. Some thought leaders say every acute severe ulcerative colitis patient that gets hospitalized needs to be seen by a colorectal surgeon. But I think certainly they should be kind of first line involved if there's surgical indications like perforation or massive bleeding. Second line, if they have toxic megacolon instability sepsis, kind of as they're trying to get their treatment. And then once you're starting to look at third line agents like JAK inhibitors, we'll talk about other sort of second, third line treatments, then we need to start thinking about getting surgery involved, or if they're kind of getting worse. And then lastly, once you're kind of after a day 7, it's probably time to get the surgeons involved, just because you want them to have the information. You don't want people rushed into a decision to have surgery. And also because, if a delayed and prolonged hospital stay will increase the risk of postoperative complications. And in general, if patients need a colectomy, they should, go ahead with that. So anyway, I think this is a nice little timeline to think about when a surgeon should absolutely be involved. And I think it's appropriate kind of as you're not seeing response to the initial rescue therapy to get surgeons involved while you're maybe teeing up your third line therapy. All right, so since you asked this question, I'm going to ask you, what options besides infliximab do we have for rescue therapy?
You're right. I wrote a book that I just mentioned, and then I've never seen them before, but cyclosporin is one.
Yeah, perfect. Exactly. So anyway, we have cyclosporin, which I've never used. I don't think it's been used for our IBD patients probably in a few decades at UCSF, but it is still part of the armament, and there are certain centers that have a lot of experience with it and continue to use it. It's a rapid acting calcineurin inhibitor, contraindicated for patients with low cholesterol levels because it increases the risk of seizure. And it also is contraindicated in people with renal insufficiency. It's very onerous because you have to give it as a continuous infusion, and you're titrating it to target this cyclosporin blood level concentration with a plan to bridge to oral cyclosporin, followed by maintenance with something like thiopurine or vedolizumab. So this is very much like our old school pre-infliximab way of doing things. And there's still some centers that will do this as for, if the patients had failed infliximab previously. But we can also think about using other biologic agents. And so I think something that came up that really shaped our decision not to try additional biologics, like to try adalimumab or to try ustekinumab as an additional line therapy, is that there was this study that was published in 2008 that looked at cyclosporin followed by infliximab. And essentially the thought was that this didn't improve colectomy-free survival, and because it was sort of like you were triply immunosuppressing people with steroids and then these long-acting immunosuppressants like cyclosporin and infliximab. So the idea was that really we shouldn't be doing sequential therapy, was what the takeaway from this initial study was. But then with the introduction of JAK inhibitors, initially tofacitinib, which is a pan-JAK inhibitor, and then upadacitinib, which is a specific JAK inhibitor, there's been a lot of interest in using this for rescue therapy. And so this is, like I mentioned, the new kid on the block. And the way this came about is that the initial clinical trials for Octave, which looked at tofacitinib, people started feeling better really quickly within 3 days of starting therapy. And now it's part of like the marketing and all of that for these drugs as well, rapid response. But then that lends itself to use in the hospitalized setting because we can, really get patients turning around quickly. And the reason we hadn't used other biologics, in addition to the concern about immunosuppression, is that they were just too slow. Like we just didn't have time to have patients sit in the hospital for weeks to wait for their biologic therapy to kick in. And so we actually published our experience with this in 2020, looking at 4 patients at UC that were all discharged within 3 weeks of being hospitalized, and were all colectomy free for patients who were TNF experienced, rather than if they failed steroids, they would just have to go to surgery. And then this follow-up study in the Journal of Crohn's and Colitis showed that sequential use of high-dose tofacitinib after infliximab was not associated with adverse events. And so that kind of gave people the courage to consider third-line therapy or sequential therapy after failure with infliximab. And so that really kind of changed the paradigm in terms of, okay, well, we can think about second-line therapy, put JAK inhibitors into the mix, and then maybe not actually, if they're medical therapy failure, after they fail TNFs, they fail JAK inhibitors, then that's maybe when they would need to go to surgery. And as I mentioned, the data for upadacitinib, in particular, because it was just FDA approved for ulcerative colitis in 2022, the data we have for use in acute severe ulcerative colitis is pretty limited. But you can see here in this kind of case series that was published about 2 years ago that you can see significant improvement basically in 5 out of 6 of these patients with regard to bowel wall thickness on intestinal ultrasound, calprotectin normalization, and then being able to, seeing their CRPs really kind of dive down considerably. So really kind of promising that patients are doing well with the selective JAK1 inhibitor, upadacitinib, for acute severe ulcerative colitis. And so because, again, there's not a ton out there, really it's case series. There was now just, this past year, systematic review that looked at this question. Okay, well, what does it look like now with this sort of, compiling all of the studies that have been published with really small numbers. And so a total of 55 patients across 11 studies, saw a colectomy rate of 16%. So it's not, not single digit percent. It's still, we're seeing colectomy rates that are, close to what we were seeing previously, but certainly numerically, at least 16% is lower than what we are seeing in the sort of infliximab only area, that 20 to 30% colectomy rate at 90 days. The reports of steroid-free remission were 80%. So patients who do respond tend to respond quite well. And then low rates of adverse events with 2 thromboembolic events, which I actually think is, although it's kind of cited in this paper as low, I actually think is a little bit higher than we've seen in our cohort of hospitalized patients with IBD. Our rates of VTE are exceedingly low. It's like, in the 0.1%, range or something along those lines. So anyway, I think that does raise some questions about upadacitinib and VTE, and probably more importantly about making sure patients get VTE prophylaxis. All right, so our case is continued. The patient agrees to off-label use of upadacitinib after infliximab failure, and after 3 days of upadacitinib 45 milligrams, he's getting better. Abdominal pain's better, bowel frequency's better, his CRP decreases. So my last question let's see, let me see who, any last folks that haven't answered. Okay, Team VA, maybe I can ask you guys, how do we know when he's ready for discharge?
I don't know what the exact criteria for boxes you would check, but I would definitely check to make sure that their symptoms are like under tolerable control, like they're having like less than like 4 or 5 bowel movements per day. Their pain is manageable without requiring like specific pain therapies. They're able to maintain like good PO nutrition and diets and like just in a state where they would thrive at home.
I love it. That's perfect. So manageable bowel frequency, minimal rectal bleeding, less than 25% of bowel movements, ability to eat and take care of themselves, and that they've got adequate pain control. So that's what I also will tell patients at the outset, like that is what they are working towards. And then, obviously, like we don't want them to be tachycardic and febrile when they're leaving. Logistically, the other things we want to make sure is that they have a follow-up appointment with an outpatient IBD provider, that insurance authorization is cooking for outpatient therapy, although in this day and age now with increasing, burden of prior authorizations and red tape, that we have, unfortunately do come across situations where we can't get outpatient therapy approved in time. And so the patients have had flares and lapses because of this. But at the very least, we want that insurance authorization underway for their outpatient therapy. And then if they need any follow-up imaging, if they were hospitalized for an abscess, for example, we want to make sure that it continues to shrink and not be present. So this is a question that comes up a lot that we talk about when we're managing these patients. Do we need to actually watch these patients in the hospital after we transition them from IV steroids to oral steroids? And this is something that our group published earlier this year that really showed that monitoring patients, it doesn't really prevent that many, like wouldn't necessarily prevent that many rehospitalizations. Of all the patients that we watch, about 11 out of 160 required transition back to IV steroids. Because that's what we're worried about, right? Is that we put people on PO steroids and that they're not going to do well, and then they're going to need to go back on IV steroids. And if we send them home too quickly, then they'll come back and it'll be a readmission. And we'd rather just keep them in-house than have them go through the rigmarole of a readmission. But I would say the failure rate of transitioning from oral steroids back to IV steroids or readmission, this is what was captured in transition failures, is really low. And so I think it's probably a little bit overkill. And again, something that we're doing probably to treat ourselves more than the patients. And if the patients are amenable to leaving, I think that our data suggests that it's probably safe in patients who are motivated and we think are relatively low risk for treatment failure to be able, based on our clinical judgment, to be able to leave the hospital without that 24 hours of monitoring. So I think that's a part of the paradigm I think that would be good to sort of continue to challenge and see, and we'll continue to follow that as we are continuing to collect data from our inpatient IBD cohort.
Sara, can I ask a question on that?
Yeah.
In your practice, if you are doing, maybe like a sort of a quick discharge, do you have like in your head, like an automatic, like a nursing call a couple days later or a clinic visit? Like, do you do anything on the back end to follow up these patients sort of like maybe informally outpatient when you're not doing extended monitoring?
Yeah, I mean, I think that it depends I think on the patient, right? And so actually, you know, as protocol for all patients discharged from UCSF Health, they will get a nursing discharge follow-up, but generally from the hospital as opposed to from our clinic. If patients are plugged in with our clinic already, they're probably already messaging and calling and very plugged into our care team. So there's no sort of proactive follow-up protocol that's there, but typically we are trying to get patients follow up sooner rather than later. And they certainly, if there's any concern or question, especially for patients who are like, they've been hospitalized before, they've done this before, know to reach out and get care quickly. But yeah, I think that, you know, we sort of think about you know, that's an extra hospital day, extra exposure, increased costs, all of that. And so I think the question of what is the value of that practice, especially. But, you know, I think especially if you could sort of advocate for like a nursing follow-up program, maybe that would sort of help to encourage people and make patients feel more comfortable doing that. Okay. One last word about Crohn's hospitalization. So just, you know, I talked a lot about the enterocolitis management piece of things, but for stricturing Crohn's disease, you know, if you have an inflammatory stricture, it typically resolves very quickly with IV steroids. You can use infliximab if that's the case, and then potentially other rescue therapies as well, but typically surgical resection, or maybe even sort of interventional endoscopic techniques like a endoscopic stricturotomy may be used. But otherwise, same management to similar to small bowel obstructions, and they often can be on the hospital medicine service if we think it's inflammatory. And then for penetrating Crohn's disease, antibiotics obviously is the mainstay, IR or surgical drainage, and then think about follow-up imaging and tube checks may be required on discharge if they have a persistent drain. So those are kind of the principles of those, but those are a little bit more straightforward in terms of, you know, it's like we don't immunosuppress those patients. We just give them antibiotics, try to taper their steroids if they're on them, hold their biologic or small molecule therapy. So with that, I will pause here. These are some future frontiers I'm super excited to talk about in terms of outpatient care, better pain control, prolonged VT prophylaxis, hyperbaric oxygen, so many exciting things that are kind of coming down the pike in terms of management, but I'll pause there to see if people have questions and let you all have a wonderful rest of your morning. And thank you so much for your attention and engagement.